Welcome to revision series lectures in cardiology for the upcoming exams. Now, as far as revision series lectures are concerned, it's trying to consolidate everything together and trying to give you the maximum information in the least possible period of time. So obviously, we are going with weightages than out of interest, because for any cardiologist to ask him what is interesting most in cardiology, he will tell you ACS and MI and all those things, and then of course the arrhythmias and stuff. But that is not how the exam is. For the last exam, we have had just one single ECG question that was on a hyperkalemia ECG, not a cardiac ECG per se. Then of course for the previous years, we didn't have any questions on ECG. So that's why that is not the exam zone as far as we are concerned. In these series of lectures, we'll be looking into our discussion on clinical cardiology, and that is where we get majority of these questions, in fact 5 or 6 questions in total. And clinical cardiology lectures have to be focusing on AS, AR, MS and MR. They are very, very important, and even from the middle of your sleep, you should be able to tell the clinical points of difference, especially with respect to the heart sounds, especially with respect to the pulse, especially with respect to the BP and JVP. Extremely important to study. Then of course, at the same time, you should be knowing certain important points with respect to heart failure, especially the drugs. A very, very, very important question. Cardiomyopathy, again, very important to know DCM and HCM. HCM, of course, is the most important cardiology topic for generations together. RCM has to be studied always in comparison with chronic constrictive pericarditis, and chronic constrictive pericarditis has to be compared with cardiac tamponade. So these are going to be the most important pivotal topics. And of course, knowing the heart sounds, important entrance questions on S1, S2, S3, S4, the opening snap, the pericardial knock, the tumor plop, and all these things. So that is together what we are actually going to discuss. And this is going to be a very important discussion, because 5 to 6 questions are going to be mandatorily asked from here. It's a very conceptual topic. So when you study this, we have taken the extra time and gone into the concepts, because you can mug it up also. But when you mug it up, to reproduce it into the heat of the exam may not be actually possible. So conceptually study it in the beginning, and this module, when I'm trying to do the revision, I'll try to do concept and mugging. Wherever we can use the concept quickly, we will use it. Wherever it takes time, we will drop it and go to mugging. So whichever way, I think both ways are possible. And I'm a person who wants to mix it up in the right proportion. I never want to tell you that it is conceptual study that is the key to success in an exam. That is absolutely not. Mugging up is equally important. So that's how we'll be trying to approach this. And I think this should hold you in good stead. It's one easy zone as far as scoring marks are concerned. If you know this properly, you will never forget it also. So you can actually score very easily for the exam. So important topic, and focus on these areas. And that is what we'll be trying and doing. So as far as the exam is concerned, this is the cardiology that we need to really focus on. Welcome to this revision module on aortic valve disorders. So without wasting any time, let us go to the business end of things. As far as aortic valve disorders are concerned, the discussion is going to focus on aortic stenosis and aortic regurgitation, extremely important for the exam. So let us quickly look into the key points on this aortic valve. I've told you aortic valve is a valve which the surgeon definitely likes to operate much more than the mitral valve, because mitral valve is a 3-dimensional valve, extremely complicated. Aortic valve is a 2-dimensional valve, which is much less complicated. If you look into the aortic valve per se, the aortic valve has generally 3 leaflets, which we call as our cusp. Then there are 3 commissures, okay? And these leaflets are being attached to one fibrous annulus. So we are having 3 leaflets, 3 commissures, and one fibrous annulus. Very important to note that there are no chordae here, there are no papillary muscles here, nothing like that, only 3 structures. Now here comes the first major question, that normally a person is born with 3 leaflets, but there can be people with 2 leaflets, and there are few people with 1 leaflet also. So 3 leaflets, 2 leaflets, 1 leaflet, and some people are even having 4 leaflets. So unicuspid, bicuspid, etc. Key point is, lesser the number of leaflets, more the chance for stenosis, which means 1 leaflet means you are definite to have aortic stenosis. 2 leaflets also means you are having high chance for stenosis. 4 leaflets means you are having extreme high chance for regurgitation. So more the number of leaflets, more the chance for regurgitation. Less the number of leaflets, more the chance for stenosis. And normally we have 3 leaflets. That's why it's been repeatedly asked for the exam. Quadricuspid valve means more chance for regurgitation. Bicuspid and unicuspid valve means more chance for stenosis. Maximum chance for stenosis in unicuspid valve. Even bicuspid valve also, we are having enough chance for stenosis. 3 leaflets is normal, and 4 leaflets is equal to more chance for regurgitation. So this is the basic understanding that you need to have out of this valve. Now we are actually going into the crux matter, and that is the proper topic, which is aortic stenosis. So aortic stenosis and aortic regurgitation are 2 so important topics that you cannot get an exam in our country without actually getting a question on this. And sometimes the question may be on a basic science issue like a pulse, BP, JVP, like that, which we'll obviously see separately. So let us try to understand what is this aortic stenosis. And if you're asking me what is aortic stenosis, we are having the substrate. What is our substrate? Our substrate can be this tricuspid valve or a bicuspid valve. I told you, most people are having tricuspid valve. Some people have only 2 leaflets, that is called as a bicuspid valve. On top of the substrate is a tricuspid or a bicuspid valve. When you are having degeneration bar calcification, okay, when you are having degeneration bar calcification on top of the substrate, that is bicuspid or this tricuspid valve, then that is actually called as aortic sclerosis. So degeneration bar calcification on top of this tricuspid or bicuspid valve is called aortic sclerosis. And few people with aortic sclerosis go on and develop stenosis, that we will see. So only few people with aortic sclerosis go on and develop aortic stenosis. That is why it is extremely important to understand that the major cause for aortic stenosis is basically aortic sclerosis. So without having aortic sclerosis, you will not get aortic stenosis. Aortic sclerosis occurs in the young patient as well as aortic sclerosis occurs in the elderly patient. When aortic sclerosis occurs in the elderly patient, then it is degeneration and calcification. Okay, it is due to degeneration and calcification, and the substrate is most often a tricuspid valve. So the substrate is most often a tricuspid valve. When aortic sclerosis occurs in a young patient, then 100% the substrate is bicuspid valve. So young patient having aortic sclerosis, that is degeneration calcification, substrate is bicuspid valve. Elderly patient having degeneration calcification, then the substrate is a tricuspid valve. This is very important, and that is why as far as aortic stenosis is concerned, this rheumatic etiology is more or less non-existent. You generally don't see. So don't ever think that the most common cause for aortic stenosis is rheumatic. Rheumatic is very rare. And at that point, please to understand that when you develop an acute rheumatic fever, okay, when you develop an acute rheumatic fever, you may have valvulitis. Sometimes you may have, sometimes you may not have valvulitis. In valvulitis, most common to get is MR. Valvulitis, most common valvular heart disease is MR. And second most common is MR plus AR. Okay, so first combination is MR, second combination is MR plus AR. More common is MR in valvulitis. After valvulitis, generally the period is around 15 to 20 years. After 15 to 20 years of valvulitis, you get the rheumatic heart disease. And in rheumatic heart disease, the most common combination is MS plus MR combination. So the most common combination in a rheumatic heart disease is MS plus MR combination. Second most common combination in a rheumatic heart disease is MS plus AR combination. So second most common combination is MS plus AR combination. And the least common combination that we get is a AR predominant plus AS combination. So MS plus MR most common combination, MS plus AR second most common combination, AR plus AS is the third most common combination, of which AR is predominant. Here MS is mostly predominant, other way MR is also possible. Here MS is mostly predominant, sometimes AR is possible. But in AR plus AS combination, it is almost always AR that is predominant, which means that AS to get as a rheumatic etiology is extremely unlikely. So the most common cause for AS in a young patient is bicuspid aortic valve degeneration calcification. In elderly patient is equal to tricuspid aortic valve degeneration calcification, and this degeneration and calcification is basically what we call as sclerosis. And now we understand that sclerosis is not just a degeneration. The update is that sclerosis is more of a inflammatory thing, and it is associated with atherosclerosis. So sclerosis is an inflammatory thing, so that is why it is associated with atherosclerosis, and hence it is mandatory to take up every patient who is being diagnosed with aortic stenosis for an angiogram before you go ahead with valve replacement, because this is a part of atherosclerosis. You may see atherosclerotic lesions in the coronaries also. It's very common to find that, and because of that, the valve replacement has to go hand in hand with the bypass surgery, and very often it is a valve replacement with bypass surgery that is being done. That is because of this understanding that this is not simple degeneration calcification. It is basically equal to inflammatory process. Previously it was considered as a degeneration thing only. Now it is considered to be inflammatory, lipoprotein, RAS activation. So many things have been implicated in that. Okay, so as and when you are coming across this, your main priority is to know whether the patient has a bicuspid aortic valve or the patient has a tricuspid valve. And when the patient has a bicuspid aortic valve, very often the patient is a very young patient, and tricuspid aortic valve is associated stenosis is seen only in more than 60 years. So young patient bicuspid, otherwise tricuspid. Bicuspid aortic valve means two things you have to be extraordinarily careful for your exam. Bicuspid aortic valve is associated with this notch 1 defect. Okay, which is endothelial nitric oxide synthase defect. Okay, endothelial nitric oxide synthase defect, notch 1 defect. Both these are more common in males. Aortic stenosis due to some reason is like so common in males. 80% of the patients are males here. Second point about bicuspid aortic valve is whenever you find a bicuspid aortic valve, the surgeon is a little more circumspect because it's easy to operate on a tricuspid valve. It is not that easy to operate on a bicuspid valve. And along with the bicuspid valve, always there is a high chance for aortopathies. That is the reason why whenever you have a bicuspid valve, it is mandatory to take a CT aortogram, because CT aortogram is to rule out aortopathies, especially aneurysms, etc., etc. So when it is a tricuspid valve, there is no reason to take a CT aortogram. But when there is a bicuspid valve, you have to take a CT aortogram because there is a high chance for aortopathies which are associated with this. Okay, so this much is clear. The basic background is clear. Let us see what is the hemodynamics in aortic stenosis. So whenever we study the hemodynamics in any cardiac disease, we have to be knowing about the 3 phases in systole and the 5 phases in diastole, okay, which have been discussed in detail already many a times in the video. So 3 phases in systole are isovolumetric contraction, rapid ejection, reduced ejection. So isovolumetric contraction, rapid ejection, reduced ejection. The 5 phases in diastole are protodiastole, which even if you don't know is okay. Then isovolumetric relaxation, rapid filling, reduced filling, and atrial systole. So these are the 5 phases in diastole, the 3 phases in systole. Okay, now in aortic stenosis, what is the focus? The focus in aortic stenosis is on systole, because it is systole that we're talking about. It's ventricular systole. 0.3 seconds is the duration of ventricular systole. 0.5 seconds is the duration of ventricular diastole. When I say systole diastole, it's ventricle. Otherwise, you have to mention atria specifically, where 0.1 seconds is systole, 0.7 seconds is diastole. So here it is ventricle. We are focusing on this particular point. This particular point is the point where the ventricle is contracting as a closed chamber. So that is why it's called isovolumetric contraction. Volume doesn't change. So the mitral valve is also closed, the aortic valve is also closed, and the ventricle is contracting as a closed chamber. It is at the end of isovolumetric contraction. Okay, it is at the end of isovolumetric contraction that the aortic valve opens. So end of isovolumetric contraction, the aortic valve opens. And the beginning of isovolumetric contraction, you have the mitral valve closure, and you know systole. That's why I told you from IVC to end of rapid ejection phase is the systolic phase. So S1 occurs just before IVC, and at the end of IVC, the aortic valve opens. Aortic valve opening is generally not associated with any sound as such, but sometimes we can get ejection clicks. So that is why ejection clicks may be heard when the aortic valve opens. Aortic stenosis patients sometimes have ejection clicks, especially when they're having a bicuspid aortic valve. There is a chance for a click. So let us come to this. After which there is rapid ejection, and then there is reduced ejection. So let us see what happens. Normal in systole, the pressure in the LV and the pressure in the aorta. What is the pressure in the LV? Systolic pressure 120 millimeters of mercury. What is the pressure in the aorta in systole? Again 120 millimeters of mercury. Meaning that during systole, there is no gradient between the LV and the aorta. Correct, during systole, no gradient. So if there is a gradient between the LV and the aorta in systole, how is it? It's not possible. Why is it that there is no gradient between the LV and the aorta in systole? That is because the aortic valve opens completely. So the aortic valve opens completely, and there is absolutely no gradient between the LV and the aorta. And that is why it's very important to understand that in a normal person, the afterload is a resistance against which the LV is contracting. The afterload is provided purely by the aorta, nothing by the aortic valve. The valve is not responsible for any kind of an afterload. Afterload is a resistance which is offered by the aorta as a vessel. Valve is not responsible for any resistance, and there is absolutely no gradient between the LV and the aorta during systole. Correct. Now we are going to comment about aortic stenosis. So just tell me what happens in aortic stenosis. We are actually getting what? We are getting a resistance. That means the valve is not opening completely. When the valve is not opening completely, naturally you will develop a gradient. And it is the gradient who is the kingmaker as far as the disease is concerned. And this gradient is naturally equal to the severity or directly proportional to the severity. So in systole, there is absolutely no gradient between the LV and the aorta because the valve opens completely. When the valve doesn't open completely, there is a gradient created between the LV and the aorta, and this gradient is directly proportional to the severity of the disease. And in this disease, everything we talk about with respect to the gradient only. Correct. That is very, very clear. And that is why whenever we talk about aortic stenosis and when we talk about the severity of aortic stenosis, you have to be knowing about this term called 40-4-1 rule. 40-4-1 rule means that whenever the transvalvular pressure gradient, okay, that is the gradient that I'm talking about, transvalvular pressure gradient, we call it as the mean transvalvular pressure gradient, is more than 40 millimeters of mercury. Okay, more than 40 millimeters of mercury. The peak flow velocity across the valve, the peak flow velocity across the valve is more than 4 meter per second, and the aortic valve surface area, okay, aortic valve surface area is less than 1 centimeter square. Okay, so 3 to 4 centimeter square is normal. So less than 1 centimeter square. This is actually equal to severe aortic stenosis. So what is severe aortic stenosis? Is this 40-4-1 rule is what is equal to severe aortic stenosis. It is very, very important to understand because for a normal person, he talks about severity, everything with respect to the gradient, everything with respect to the gradient. And you remember that in aortic sclerosis, the gradient is less than 20 millimeters of mercury. That's why I'm telling you, there are a lot of people who are having sclerosis, especially in the elderly population, but only few people have stenosis. What is the difference between sclerosis and stenosis? Degeneration and calcification, which is big enough to produce a gradient, is called stenosis. Degeneration and calcification that is not big enough to produce a gradient is called a sclerosis. So in sclerosis, the gradient is less than 20. In stenosis, the gradient is actually more than 40. What is the gradient? The gradient across the aortic valve, which is the mean transvalvular gradient, the gradient between the LV and the aorta in systole. Normally, it is 120 LV, 120 in aorta, no gradient. Here, we are having a gradient because of stenosis of the aortic valve. Okay, it's very clear. Now let us see what does the body do to compensate. So for every valvular heart disease, the body has to undergo some degree of compensation. Then only we can survive to maintain the cardiac output. So every compensation is basically aimed at maintaining the cardiac output, correct? Here the body tries to go for a compensation which is called as concentric LVH. So concentric LV hypertrophy is the compensation here. And this concentric LV hypertrophy is at the expense of the cavity size. That means the cavity size actually speaking reduces here, the LV undergoes hypertrophy. That's why it's called as concentric hypertrophy at the expense of the cavity size and increasing the LV mass. So the LV mass also increases here. So concentric LVH, increase of LV mass at the expense of cavity size. That is the perfect answer. Even if you say concentric LVH, that is fine. So what actually happens here? We are having a concentric LVH, and because of that, the cardiac output is maintained. So because of that, the cardiac output is maintained. That is why you will never see anybody with a mild or a moderate aortic stenosis. Mild and moderate aortic stenosis patients are completely asymptomatic, and it is very, very unlikely that you will find out somebody like this. It is impossible to find out somebody like this. Every single patient whom you are seeing with aortic stenosis is actually equal to severe AS, because it is only in severe AS that the patient is going to be symptomatic. And there is one more entity called very severe AS. Very severe AS is characterized by LV failure. And this is the other set of patients where surgery may not yield that good results. So the aim is to find out everybody in the case of severe AS. Correct. It is not to figure out the very severe AS, because very severe AS, even if you do surgery, the prognosis may not be that great. But severe AS symptomatic patients, we have to identify and take them up for surgery, which is associated with excellent results. So mild and moderate AS as an entity does not exist. Severe AS is when the patient starts becoming symptomatic. Then they can go for very severe AS where the LV fails. And at very severe AS, if you do surgery, the prognosis is not as good as severe AS. So severe AS is the time that you have to find out and do surgery for every single patient. Let us see what are the symptoms at the time of severe AS. Symptoms in aortic stenosis is called ASD532. What is the meaning of ASD532? Two numbers you have to know. 44 one I already told you. 532 I am teaching you now. What is the meaning of ASD532? A stands for angina, S stands for syncope, and D stands for dyspnea. So angina, syncope, dyspnea. That means 5 years from the onset of angina, if you don't do surgery, then the patient is not likely to survive. 3 years is from syncope. That means from the onset of syncope, if you don't do surgery, patient unlikely to survive beyond 3 years. 2 is dyspnea. So from the onset of dyspnea, if you don't do surgery, patient unlikely to survive beyond 2 years. So that is called 532. So angina, syncope, dyspnea, 532. And let us see the symptoms. So the 4 first rank symptoms in cardiology are angina, syncope, dyspnea, palpitation. That's what we are discussing here. Palpitation is related to volume overload. This is a pressure overload situation, and even the cavity is on the lower side. So you can't even think of palpitation in this condition called aortic stenosis, which means we are thinking of only angina, syncope, and dyspnea. What is the reason for angina in aortic stenosis? The reasons for angina in aortic stenosis is one, the increase in LV mass. This increase in LV mass, actually speaking, increases the oxygen demand. Second reason is the decrease in capillary density with respect to wall thickness. Okay, this is more actually speaking for a viva. So decreased capillary density with respect to wall thickness is the second reason. The third reason is that during tachycardia, you are having reduced perfusion time. So many times there is tachycardia, so there is reduced perfusion time. And 4 is the associated atherosclerosis. So 4 is the associated atherosclerosis, tachycardia, reduced perfusion time, decreased capillary density, and increased LV mass. Syncope is actually due to, and angina is often the first symptom. Syncope is due to a fixed cardiac output state. The cardiac output does not seem to increase with exercise. So my cardiac output is okay when I'm walking, but when I'm running, the cardiac output is not increasing. That is a LV outflow obstruction. That is what syncope stands for. That means cardiac output is not increasing with response to exercise. So LV outflow obstruction, that is syncope. And D is dyspnea. Dyspnea in cardiology is very, very important to understand, equal to increased filling pressure. So whenever you are having increased filling pressure, you will always get dyspnea. So that is the whole point. Let us try to make it a bit more complicated. Complex things have to be complex. You can't make it simple. And a good teacher is somebody who makes complex things complex itself. So increased filling pressure is the pressure that is required to fill into the LV. So that is why this rule in cardiology that LV end diastolic pressure, which is equal to your filling pressure, or the pressure that is required to fill the LV, is equal to your left atrial pressure, LAP, is equal to your pulmonary capillary venous pressure or pulmonary capillary wedge pressure. So this is the basic rule. LVEDP is equal to LAP is equal to pulmonary capillary wedge pressure. So when you're having this much degree of LVH, such a big degree of LVH, then your LVEDP has to increase. That is, your filling pressure has to increase. More pressure to fill into the LV, which is hypertrophied. So naturally, your LAP will increase, correct? When your LAP increases, the pulmonary capillary venous pressure will increase. So fluid will escape into your pulmonary interstitium. So fluid into the pulmonary interstitium from your pulmonary capillaries, and that will actually lead on to dyspnea. And more fluid means you will have orthopnea, paroxysmal nocturnal dyspnea, even acute pulmonary edema presentation. Anything is possible. But very, very important to keep in mind that filling pressure is what is equal to dyspnea. And filling pressure is the pressure which is required to fill the LV, which is LVEDP. Here LVEDP will increase because of LVH. So these are the three major symptoms. Okay. Very, very clear, and never forget this rule called 5-3-2 rule as far as symptomatology is concerned, and there is no role for palpitation. Specific points that you have to remember are: one, atrial fibrillation; second is systemic hypertension. Two very, very important points. Atrial fibrillation means that here generally what happens is the atria are responsible for 25% of the cardiac output, correct? Here what happens is that there is so much of resistance to filling at the level of the ventricle that the atria has to contract more vigorously to fill blood into the ventricle. So here atria will contribute to almost 40% of the cardiac output. So that means that if the patient goes for atrial fibrillation, then this 40% is gone. That is why AFib is fatal in AS. You basically can't live with AFib. AFib is the worst thing that can happen to AS patient. He will not tolerate. Second is hypertension. Hypertension seems to mask aortic stenosis. What is the meaning of masking aortic stenosis? When hypertension is there, your systolic BP is high. So what happens? Your aortic pressure is high. We are talking always with respect to gradient. Gradient is between the LV and the aorta. Okay, so a person is having aortic stenosis, LV is very high, aorta is normal, the gradient is actually high. But if you're having BP or if you're having hypertension and that is not controlled, then your aortic pressure will also be high. So what will happen? You will see a falsely low gradient, correct? Because of the high aortic pressure, you will be seeing a falsely low gradient and you may be taken off. You may think that, okay, this is not severe aortic stenosis because the gradient is not that much there. But that gradient is low because of the aortic pressure high due to BP. That is why strict control of blood pressure is very important. Okay, strict control of BP is very important because otherwise it can mask aortic stenosis. So very important, strict control of BP and atrial fibrillation can be fatal in aortic stenosis. Very important to understand. Clear? That's it. Now we will try and see how do we diagnose this. To diagnose aortic stenosis, you require only a transthoracic echocardiogram, and on a transthoracic echocardiogram, it is this 40-4-1 rule that we are looking for, and I have told you everything about 40-4-1 rule. Nothing else is required, but it's also very important to keep in mind that angiogram is required in everyone because this is associated atherosclerosis, so you have to be looking for that. In that case, surgery should be accompanied with a bypass, and also always keep in mind that CT aortogram is mandatory in somebody who is having a bicuspid valve because there is a chance for aortopathy. And we have something called dobutamine stress test, dobutamine stress echo, which is also very, very important to understand because you may be having a patient who has a low gradient. Okay, so that is what is called as low flow, low gradient. When there is low flow, low gradient, then there is no chance for severity. You mean that there is nothing severe in this, it is mild. When peak flow velocity increases, as peak systolic velocity increases and gradient increases, that is when you say that it is severe. But there is a chance that somebody has very severe AS, correct? In very severe AS, the LV fails. In very severe AS, the LV fails. When the LV fails, you can have low flow, low gradient AS, correct? So low flow, low gradient AS is possible when you are having very mild AS. At the same time, in LV failure also, you can get a low flow, low gradient AS. So to actually differentiate that, you are doing a dobutamine stress echo. Just have to know the details of it are not required, which means in very simple terms, I'm telling you, there are two patients with LV failure. Okay, there are two patients with LV failure. One person with LV failure has got a mild AS accompanying that. Mild AS accompanying that. AS is not significant, LV failure is significant. Second is a patient who has got AS and because of that he has got LV failure. So this patient needs to be managed medically for LV failure. This patient, because AS is responsible for LV failure, the valve has to be replaced. But both of them will have low flow, low gradient. In that case, the test that is done is a dobutamine stress echo. Just slightly more higher point. Correct? Now we go to the last part before we go to how to manage the clinical features which are asked left, right, and center for the exam. What happens to pulse? What happens to BP? What happens to JVP? What happens to the apex? What happens to S1, S2, S3, S4? And then we will see the murmur. So very simple understanding. Pulse is basically called as the slow rising pulse. So that is an MBBS level understanding. So mild and moderate AS, nothing happens. You have to understand that in severe AS and very severe AS. So when LV fails, it is called very severe AS, otherwise it is called severe AS. In severe AS, we have this pulsus tardus, okay, pulsus tardus, and very severe AS, we have this pulsus parvus et tardus. So what is the difference between pulsus tardus and parvus et tardus? Tardus means that you are taking more time, but still you are reaching the peak. It's just that you're taking more time. Parvus et tardus means you're taking more time, still not achieving the peak. So taking more time, achieving the peak is tardus, that is severe AS. Very severe AS means taking more time, still not achieving the peak. That is called as parvus et tardus. BP is always about LVH, okay? Always keep in mind disproportionate LVH, elderly person. Think of this LVH with strain and all those things. And also keep in mind that it can mask aortic stenosis, correct? Because the higher pressure in the aorta may result in a lower gradient. So controlling BP is very, very important. The moment you talk of JVP in AS, you are failed for the exam because JVP is right-sided thing, this is a left-sided thing. And JVP, if at all elevated as a terminal event in AS, that means the patient is about to die. So there's nothing about it. Then we come to the apex. Apex is a not going to be displaced downwards because there is no cardiomegaly here, but some lateral displacement will be there. It's very important to note that it is a high amplitude sustained apex. This high amplitude sustained apex is what we call as the heaving apex. Okay. So high amplitude sustained apex is what we call as the heaving apex. That's it. Okay. Then we come to the heart sounds. Heart sounds, again, very, very important question as far as aortic stenosis is concerned. And with this aortic stenosis, we'll study the mechanisms also. So S1 in aortic stenosis, there is no mention to make because S1 has got nothing to do with aortic stenosis. It's aortic valve, there's a mitral valve. But remember that aortic ejection click, okay? Aortic ejection click may be confused with loud S1. So please keep it in mind. Aortic ejection click. If you get a loud S1 in aortic stenosis, never say it is loud S1. It is mostly ejection click. S2 in aortic stenosis. S2 in aortic stenosis, you have to be keeping it in mind. You can have a loud S2 or you can have a soft S2. And most often it is the A2 that we are actually talking about. If it is a bicuspid aortic valve, then it is likely to be loud. Degenerative calcific elderly patient having from a tricuspid valve, then it is likely to be soft. So elderly, it is likely to be loud and elderly soft and young patient loud if it is on a substrate of a bicuspid valve. Then you can have reverse split. Reverse split means that there is more time for the LV to fill because there is a hypertrophy over there and the right side actually fills more easily. So reverse split, or what we even call as a paradoxical split. So reverse split, or what we call as a paradoxical split, where P2 occurs first and then A2. This again is generally seen in severe aortic stenosis only. Correct. So we have S2 loud in bicuspid pathology, S2 soft in elderly tricuspid pathology, reverse split, and reverse split is seen with severe aortic stenosis because the P2 fills early. So it's P2, A2. Right. Then comes S3 and S4. Let us try to understand this now, and that will actually suffice for all the valvular heart diseases. When do you get S4? S4 is when healthy atria, that is the first thing, across a non-stenosed valve, healthy atria across a non-stenosed valve contract vigorously. So healthy atria across a non-stenosed valve contract vigorously, okay, contract vigorously in sinus rhythm. That is important. Contract vigorously in sinus rhythm into a hypertrophic non-compliant, non-dilated ventricle. So hypertrophic, non-compliant, non-dilated ventricle. So this is the prerequisite. So that means every single point has to be satisfied. Healthy atria should be in sinus rhythm, that should contract vigorously across a non-stenosed valve into a hypertrophic, non-compliant, non-dilated ventricle, which means that if you take aortic stenosis, each one of this is satisfied. That is why you get S4. Atria are healthy, they are contracting vigorously across a non-stenosed valve into hypertrophic, non-compliant, non-dilated. Please look into this. MR and AR have a dilated ventricle, so you will never get S4 in MR and AR. MS means the valve is stenosed. I am telling you very, very importantly, across a non-stenosed valve. So there also you will not get S4. So if you get S4 in S4 in medicine, valvular heart disease, it is aortic stenosis 100%. Okay, then comes S3. S3 is also very important to understand. How do you get S3? S3, there are many mechanisms possible, but LV systolic failure will always produce S3. So LV systolic failure will always produce S3. That is why in very severe AS, you are 100% going to get S3. So very severe AS, you are going to get S3 because LV systolic failure is there and then, so you will definitely get S3. For you to be getting, there should be normal or less than normal filling. So LV systolic failure, always you will get. Otherwise, normal or less than normal filling of a non-compliant dilated ventricle. Okay, so non-compliant dilated ventricle can actually produce S3. Okay, or normal or more than normal filling. Okay, normal or more than normal filling of a hypercompliant ventricle. Okay, normal or more than normal filling of a hypercompliant ventricle. So when you get normal or more than normal filling of hypercompliant ventricle, that's the reason why you have physiological S3. There's nothing called physiological S4. You can get physiological S3. Pathological S3 is when it is normal or less than normal filling of a non-compliant dilated ventricle, and of course LV systolic failure. And both these things are actually speaking satisfied here. That is why in S3 can be seen in aortic stenosis, yes, but it is seen only in very severe aortic stenosis when the cavity is starting to get failed. Otherwise, it is not likely that you get a S3. Okay, so very, very important to keep this in mind. S1 is normal, S2 is loud or soft depending on the pathology, and if severe, you can get reverse split. S3 can be seen in very severe AS when there is failure, and S4 can be heard in AS, not seen, heard in AS, because it satisfies. Okay, now we come to the last part, that is a murmur of aortic stenosis. Murmur of aortic stenosis is very, very important. It's a mixed frequency murmur. That is the first point. All murmurs in cardiology are high-pitched murmurs. The three exceptions to high-pitched murmurs in cardiology are MS, TS, and Austin plane murmurs, which are low-pitched murmurs. The only mixed frequency murmur in cardiology is this aortic stenosis murmur, which is a very harsh ejection systolic murmur, right, which has a late systolic accentuation. That means soon after S1 only you will not hear this. There's a small gap after S1. Okay, that isovolumetric contraction phase, this is not there. Then after isovolumetric contraction only the gradient starts, and when the blood starts going into the aorta. So late systolic accentuation with the harsh ejection systolic murmur. Correct. That means S1 is there, S2 is there. This part is IVC. Here nothing is happening because the valves are closed. It is from this part. That means the rapid ejection as well as the reduced ejection. This is where you are actually going to get the whole story. So it is after S1, a gap, and then you are having the murmur, and the murmur will actually peak. That is called late systolic accentuation. If it is an innocent systolic murmur, like due to anemia, etc., I don't know why you call it innocent, but because anemia is even more dangerous. But anyway, so that is going to cause a murmur which is not got a peak. So here there will be a late systolic accentuation. So harsh ejection systolic murmur, late systolic accentuation, which is best heard in the aortic area and which is best heard in the sitting position. The key question is, because it is a mixed frequency, there are two parts to this. One is the low frequency part of this murmur, and second is the high frequency part of this murmur. The high frequency part of this murmur, which is a more soft blowing musical type, is going to be radiated to the apex, whereas the low frequency, which is a loud component, because E is equal to hc by lambda, nu is 1 by lambda, so frequency and loudness are inversely proportional. So low frequency part is going into the carotid and the high frequency part is going into the apex. So you'll have the loud component going into the carotid and the soft component going into the apex. That's how you auscultate also. And the soft component going into the apex is called as the famous Gallavardine phenomena. So this is again very, very important. The soft component going into the apex is called as the Gallavardine phenomena. And this is a mixed frequency murmur where there are two parts to the whole story. Okay, so I think that is all very, very clear, and don't confuse the click. Click may be sometimes confused with S1, but when you get a loud S1 in aortic stenosis, it is not loud S1, it is equal to the click. That's it. And last part of aortic stenosis, how do you manage aortic stenosis? Become a very easily manageable disease. Now, because we are having very good success with this aortic valve replacement. AVR is not aortic valve repair. There is no concept called repair in aortic valve. It is replacement. And aortic valve replacement is done in anybody who has got a severe AS. Anybody who has got a severe AS. Then there are few people whom you detect who are asymptomatic with severe AS. Asymptomatic severe AS patients, you keep them on follow-up. And asymptomatic severe AS patients, when you keep them on follow-up, if the gradient is increasing to more than 50 millimeters, because more than 40 itself is severe, if it is increasing to more than 50 millimeters, then of course you have to do, or if they develop any symptom, you have to do. I would suggest, like in our center, extra, asymptomatic severe AS also we go for surgery, because it is mandate, it is going to go into symptom at one point, and you don't want that because of a simple reason that there is an entity called sudden cardiac death. Sudden cardiac death, there are so many conditions in cardiology where there is a risk of sudden cardiac death. AS is also one such condition where there is a risk of sudden cardiac death. So asymptomatic severe also, all the book says wait till 50, it's better that you go ahead and do the surgery. And we are having aortic valve replacement has become much more better now, because we're using the bioprosthetic valves. Previously it used to be the metallic valves. Now we have bioprosthetic valves which can last for a long time. And long means, I think previously it was 5 years, 6 years, now it's 10 years, 12 years, 14 years, 16 years, like that. And they require no anticoagulation, absolutely no anticoagulation. So that is why bioprosthetic is so much preferred. And now the biggest update is that we are having this transcatheter aortic valve implantation, what we call TAVI. And TAVI is now being compared head to head. Even though now we say, okay, AVR is the best, there can come a point when TAVI can replace AVR. It's done by the cardiologist. It's not an open surgery, no ICU stay, nothing actually required. So people who are not fit for surgery, there is always an option, that is transcatheter aortic valve implantation. Cost was previously like 25-30 lakhs, but now the cost is coming down. Now we are having centers doing TAVI for 12 lakhs, 15 lakhs, etc. So TAVI is also a very practical option. TAVI is the other option in a patient who is not fit for surgery. So now who are fit for surgery, we go for AVR itself with the CTV surgeon. Not fit means we take for TAVI. Okay, this is in a nutshell how you have to study aortic stenosis.